in utero, what happens is the baby does breathing in utero, okay? And what that does is it makes the intercostal muscles more mature and developed for the baby. But they're not actually breathing per se, but they do the breathing movements to develop the intercostal muscles, okay? So they're ready to take their first breath because the intercostal muscles are developed. So if you look at this comparison chart here, it shows you the anatomy and physiology comparison of the fetus and the newborn. Respiratory, it is fluid-filled, high-pressure system that causes the blood to be shunted from the lungs through the ductus arteriosus to the rest of the body. So the high pressure is because the circulation can't get into the lungs because of the fact that there's fluid in it. Okay? When the baby is born, the lungs become air-filled. There's low pressure because now the circulation can flow into the lungs, and it increases the blood flow through the lungs for gas exchange. Increased oxygen content of the blood in the lungs contributes to the closing of the ductus arteriosus. Okay, so that duct shunts away from the lungs when in utero, when the baby's fetus. And then once the baby takes his first breath, that first breath will help to close that ductus arteriosus, so it's no longer something that allows for the shunting. Okay. Site of gas exchange, so CO2 or CO2 or O2 is the placenta. So this is where all the circulation and the gas exchange between the fetus and the mom and everything occur while in utero. It's the placenta. When it's born, it's the lungs. Circulation through the heart. Okay, so the pressure in the right atrium is greater than in the left atrium, encouraging blood flow through the foramen ovale, which is another shunt. Okay. When the baby is born, pressure in the left atrium is greater than in the right atrium, causing the foramen ovale to close. Okay. Hepatic portal circulation. The ductus venosus is also another shunt. Okay. And what it does is it causes the blood from the umbilical vein. Okay. So think of venosus vein. Okay. It shunts away blood from the mother's, from the baby's liver, actually. Okay. And it goes to the ductus venosus instead of going into the liver. And then it also goes into the inferior vena cava. Okay. So once the newborn is born, the ductus venosus closes, becomes a ligament, and then we have circulation into the liver. So the liver has very little circulation of blood. The lungs have very little circulation of blood, all until the baby takes that first breath. And all three of those shunts should close, okay? Occasionally you'll hear a murmur on a baby because one of the shunts haven't closed, sort of like for 24 hours or so. It's still open. And that usually is occurs with the ductus arteriosus or the foramen ovale, or when you hear a murmur in the baby, one of those shunts have not functionally closed yet. Okay. Thermoregulation, the body temperature is maintained by the mom's maternal body temperature, and also from the amniotic fluid that's there. Okay, and the warmth of the whole intrauterine environment. Thermoregulation, when the body temperature is maintained through a flex position, so when the baby's born, you see the baby flex, okay? And also, they have something called brown fat that adults don't really have, okay? And that helps to warm the baby up. All right, so that's some of the things that you can see, the difference right off the bat. Okay. I figured out, I changed the batteries with a little thing that's supposed to have here. Okay, so here we go again. We switch from fetal to newborn circulation, change from placental to pulmonary gas exchange. Physical forces leading to increased release of catecholamines, critical for change involved in transition to human life. So think of that. All this is occurring when the baby takes the first breath. Okay, so it's a lot going on that the first couple of minutes of the baby's life, and to work appropriately, okay, and for the baby to breathe on its own. Okay. So changes in the fetal structure, again, the perineal valley, the ductus arteriosus, ductus venosus, the umbilical arteries and the vein, okay? The heart rate of the baby will also be about the same. The heart rate in utero is like 120 to 160, the same thing will happen afterwards. And the volume of the blood volume, again, will change depending on how long or how high up the placenta is after the mom delivers, because sometimes if the placenta is above the baby's head or body, blood will go into from the placenta to the baby, so you might have a higher volume. If the baby is top, the placenta is below, the baby's blood volume could be depleted a little bit because it's going back into the placenta. So it's all a matter of when they cut the cord also. So these are the different the different ducts that you see, the shunts. The newborn blood values, again, it's a little bit higher than the normal adult. Okay, so you see the hemoglobin is 17 to 20, and that is, we think of the mimic, it's usually about 12 to 16. Hematocrit is 52 to 63% in the newborn. If you think of an adult woman, it's about 38 to about 44%. And the platelets are a little bit, they're pretty much around what an adult would have. And then if you look at the white blood cells and the red blood cells, they are just slightly, pretty much within the same as an adult's range. Okay. Slightly higher. Okay.
I have a question.
Yeah.
At what point is a baby going to breathe?
Baby was what?
Like after the birth process, the baby's first breath is initiated.
So I can get back to what was that?
The baby's first breath?
Yeah.
Like when does the initial breath happen?
When the baby comes out.
Like immediately?
They suction the baby. They usually suction the baby before it takes its first breath because of the fact that it has fluid. So if it takes its breath, they don't want the mucus to go back down into the lungs. And then as soon as they suction the baby takes a breath. And you'll see the baby does look blue. I mean, how many people saw that with the babies? They look so really scary at first. They look blue. And then all of a sudden they take a breath and start to cry and they turn all pink.
They have a lot of hair on them too, but you can find out that sheds off.
Yeah, it does. It does. I know. So it's going to be interesting if you haven't seen a bird to see all this stuff going on and knowing all this stuff that's going on in the baby's body as it takes its first breath. Okay. And that's why they do the ACOR scores at 1 minute and 5 minutes to see if the baby is able to adapt to its new environment. Okay. So the summary of the fetal to neonatal circulation is clamping the umbilical cord at birth, eliminates the placenta as a reservoir for blood. Onset of respiration causes a rise in PO2 in the lungs and a decrease in pulmonary vascular resistance, which increases pulmonary blood flow and increases pressure in the left atrium, which decreases pressure in the right atrium of the heart, which causes the closure of the perineal valley within minutes after birth. Okay, and then with an increase in oxygen levels after the first breath, an increase in systemic vascular resistance occur, which decreases vena cava return, which reduces blood flow in the umbilical vein, constricts it, and becomes a ligament with a functioning closure. Okay. So the umbilical vein is the one, it's a bigger vein, and it brings oxygen to the baby, to the fetus. Okay. And what happens is you have two smaller arteries that take the waste products away. So the vein is the larger one because it allows the oxygen to come in. The closure of the ductus venosus becomes a ligament, causes increased pressure in the aorta, which forces closure of the ductus arteriosus within 10 to 15 hours after birth. So again, that might be the murmur you might hear after birth. Okay. So respiratory system adaptation. So this is very essential for the baby to be able to live. So you know that ABCs and all that. So the initiation of respiration, they take adjustment from a fluid-filled different environments or gases, extrahuman environments. So they're trying to figure out, I've read all these different reports, what makes that baby breathe, when it comes out, So they're thinking that it could be, now you have from fluid lungs to gaseous lungs, and then they think also like the stimulation of going from a warm womb to a cool environment, okay? Or even the stimulation of the lights and sound could also cause the baby to take its first breath. The role of surfactant, surface tension, reducing lipoprotein that prevents alveoli collapse. Okay, so have you learned about surfactant and how it collapses? Okay, so you know that it's needed for the baby to be able, the alveoli to be able to, open and close. Okay. Respirations on a newborn are 30 to 60 breaths per minute. They are irregular and shallow. And another thing to remember about that is that's why you need to take the baby's respiratory rate and heart rate for 1 full minute. Okay? Because, and if you had a chance to listen to a heart rate or respiration, you know that they do have periods where they stop. And then all of a sudden they breathe real quickly. Or the heartbeat will be slow and they cry or move and the heartbeat will speed up. So those are some of the reasons why you need to take it for a full minute. Events leading to maintenance of respiratory function, okay, the initiation of respirations, expansion of the lungs, establishment of functional capacity, increased pulmonary blood flow, and redistribution of the cardiac output. So these again are, how do we maintain the baby to breathe? Again, you have to hope that the baby is mature enough and that the lungs are, the alveoli in the lungs have enough surfactant. Okay. How many people have seen a baby with respiratory distress? So respiratory distress in a baby, a lot of times you'll see it in a baby that is a cesarean section baby. Okay. Because the vaginal delivered baby is able to go through the mom's birth canal. And what happens is, at some point in time, when it's going through the birth canal, the lungs get squeezed a little bit, and that extra fluid in the lungs, okay, gets squeezed out. Okay, so you don't see it as much in the vaginal delivery. Okay. Cesarean section babies don't have that squeezing out of the extra fluid in the lungs, so a lot of times they come out and they sound like gunky. They sound like they have fluid in their lungs. Okay, so sometimes you'll see this with a baby, particularly a baby that is a cesarean section. Yeah.
What's it called when they have when they're using their accessory muscles to breathe, and they have like almost like a pain by their cytokine process?
Yeah, that's respiratory distress basically. So when you see a baby in respiratory distress, what you usually will see is an increase in respiratory rate. Okay, you'll also see the baby's nostrils flaring because it's trying to open its nostrils so more oxygen gets into its nose. Okay, you'll see that the intercostal muscles in the chest wall will start to pull in. Okay, it's a little pulling in, so you can see the rib cage of the baby. All right, and again, that's trying to get more oxygen in. And then you'll hear the sound called a grunt. Okay, and when you hear it for the first time, you're going to remember that sound. It's a sound that the baby makes trying to open his esophagus and all to get more oxygen in. Okay, so those are signs of respiratory distress. And a lot of times you'll see the nurses will take out a little paper thing that they will beat on the baby's chest to try to loosen up the fluid, and then they'll suction the baby, maybe give the baby some O2 to help the baby breathe. Okay. Is the following statement true or false? A respiratory rate of 44 breaths per minute would be considered a normal finding in a newborn.
True.
Okay, so from there, so respiratory is very important. And then this is something else that's very important. Baby is not able to keep itself warm, okay? It doesn't have that capacity for the first few weeks of life. So what happens to the baby? If it's exposed to cool air, okay, or a cool environment, what can happen to the baby is it starts to use energy to try to keep itself warm, and the energy is glucose, okay? So the baby will consume a lot of glucose if it's cold. The baby's cold. So think about it. If the baby's consuming its own glucose because it's cold, what could happen to the baby? Hypoglycemia. Okay, so and that will parallel into respiratory problems, and the baby could go into a coma, I guess, and die. Okay, so keeping the baby warm, you're going to see that it's the best thing for the baby because, again, the hypoglycemia can kick in. Okay, so what predisposes the baby to heat loss? Thin skin. Okay? So if you think about it, premature babies don't have the subcutaneous fat like newborns do. Okay, and even newborns don't have that much fat. You can see the veins sometimes on their chest wall. Okay, so what causes the baby to be predisposed to heat loss is thin skin, and their blood vessels are close to the skin surface. You can see them transparently. They lack the ability to shiver, so they can't, like, try to warm themselves with shivering. Sometimes babies look like they're shivering, because sometimes people will say, oh, it looks like you're shivering or whatever. That's really, it could be a sign of hypoglycemia when the babies get a little shaky, or it could be just an immature nervous system that they are just doing this, because they can't actually shiver, okay? They also have a limited store of substrates, such as glucose and glycogen and fat. Okay, there's a limited use of voluntary muscle activity, large body surface area relative to the body weight, so babies have big bellies, big heads, a lack of subcutaneous fat, little ability to conserve heat by changing positions, no ability to just own clothing or blanket to achieve warmth, and infants cannot communicate that they are too cold or too warm. Okay, so our job is to take the baby's temperature. I know at Valley Hospital what they are trying to do for the last couple of months is once the baby is born, even by C-section or vaginal delivery, they will take the baby and put the baby skin to skin with the mother. Okay, so it used to be we take the temperature as soon as they came out, and then people wrap them up and make them warm and all this. They don't do that anymore at Valley. What they do is just they take the baby, they do the assessment on the baby, and then put the baby next to the mother's skin. Okay, so the baby's shirt is off, and the mom is holding the baby right next to the skin, and that's supposed to warm the baby up. The goal is to have the baby next to the mother's skin for a whole hour after the baby's born. Okay, to feel as though it'll keep the baby up and also promote bonding. Okay, sometimes they will breastfeed also with the skin to skin. Okay. So there's different things out there, and there's different studies showing, like evidence-based, we've heard that expression before, evidence-based practice, that this is something you can implement and see if it's working and making sure the baby doesn't get too cold by being with the mom. Okay, mechanisms of heat exchange. So how does the baby really lose the heat? Okay, there's 4 different mechanisms that they talk about. Conduction is one of them, and that's the transfer of heat from object to object when the 2 objects are in the direct contact with each other. So, in other words, if you have cold hands and you touch the baby can lose its heat to your cold hands, okay? Or your cold stethoscope. So if your stethoscope is cold and the baby, you put it on the baby, the baby's going to lose its heat to that stethoscope, okay? Or even its bedding, so if you think about it, even when it gets weighed, they'll put that little food pad on the scale so it doesn't get the coldness of the scale. Convection is flow of heat from body surface to a cooler surrounding air or to air circulating over a baby's body surface, okay? So in other words, let's say you're giving the baby oxygen that's not warmed up, okay, that O2, can cause the baby to cool off because of the fact that you have the oxygen going to the baby. Evaporation, loss of heat when a liquid is converted to a vapor. So that is typically when the baby's first born. Okay? When the baby first comes out and is born, the baby has amniotic fluid, maybe some blood on the body, and that's why you see the nurses go and put blankets on the baby to clean it off a little bit and get that wetness off the baby, because the baby will lose its heat to the evaporation of the water from its its body. And also when the baby gets a bath. The baby gets a bath. If there's water on the baby's body, it could evaporate and cause illness to the baby. That's why you have to do the bathing under a radiant warmer, so that it's controlled heat. And then you have radiation, loss of body heat to cooler, solid surfaces in close proximity but not direct contact. So radiation is if the baby is near a cold wall, okay, not like touching the wall, that can cause the baby to lose its own heat, and the heat would go to the wall, okay, or a cold window or something that the baby might be near. Showing some examples here of baby. Let's see. Okay, so you have conduction, meaning a cold surface or your stethoscope touching the baby, and the baby loses heat to that. Okay, convection is breeze or oxygen or open window, where the baby's getting losing its heat to that. Evaporation is just when the baby is wet and it loses it to the air. And radiation is from being close to a cold window or a cold wall. That can cause the baby's heat to lose the heat to the environment. That it's not touching the wall, but it can still lose it. Okay. Thermoregulation of the baby. What thermoregulation means is a balance between heat loss and heat production. Okay, so thermoregulation, you want to make it sort of a homeostasis environment, equalized environment, so the baby doesn't lose too much of its heat, and it maintains a nice temperature. Okay, 37, 30. What is it? 37. 37. Okay, but it's 97.7 Fahrenheit, it's about 99 degrees Fahrenheit. Okay, so heat production is primary through non-shivering chemogenesis, so the baby can't shiver. Heat loss is four mechanisms from cold stress. There's a need for that neutral thermal environment, which means that it's, the baby is in a neutral environment where it maintains its temperature, not losing it, and it's not increasing temperature beyond what it should be. Okay, because having high temperature is not good for the baby either, for the brain. Okay, so that's why when the babies are on those radiating heat devices that they're under to stay warm, sometimes the nurses will allow the baby's, temperature to go up, really. And you don't want the baby's temperature to go up beyond like 99 or so. Okay, so you really want to keep it within that normal range for the baby, because being too hot or too cold can cause problems. Okay. Let's see. Overheating, large body surface area, limited insulation, limited sweating ability. So that can cause the baby to overheat. Okay. Then we move on, I guess, to the hepatic system. Okay. Iron storage occurs in the fetus the last 3 months before the fetus is born. It starts to store iron from the mother. It also stores glucose from the mother the last 3 months while it's in utero. So if the baby is born prematurely, okay, that means the baby doesn't have a lot of glucose and it doesn't have a lot of iron. So if it was born 3 months early, it doesn't have any of the amounts of glucose or iron. Okay? So this all occurs usually the last 3 months. Okay? The carbohydrate metabolism occurs in the baby. Bilirubin condensation occurs. 3 groups of jaundice based on the mechanism of accumulation of bilirubin. So, how many people have seen babies that are jaundiced? Okay, so usually the jaundice starts in the sclera of the eyes of the baby, the mucous membranes, and it goes from head to toe. So bilirubin levels, again, it depends on the date of how old the baby is, date-wise, and it is like they have like a scale of what numbers are normal for each day for the baby. They usually don't like to see the bilirubin above 12. Okay. But again, if it's premature, there's different numbers for it. Or if the baby is 6 days old versus newborn, there's different numbers for it. Okay. So what happens is it causes the baby to have bilirubin in a normal healthy baby to have jaundice. It's overproduction of the bilirubin. Bilirubin is a side effect or a product, a byproduct of breaking down of the heme and hemoglobin. Okay, so the breakdown of the hemoglobin causes the baby to have bilirubin in its blood. Okay, decreased conjugation of it. Okay, it needs to go through the liver to get conjugated, and impaired excretion. So some of these are the things that causes the baby to become jaundice. Okay, so remember, babies have immature livers. Okay, babies have fetal hemoglobin, and fetal hemoglobin have a shorter lifespan than adults. Okay? And when the hemoglobin starts to break down, the byproduct is bilirubin, and the baby accumulates the bilirubin in the blood, and what happens is it has to go through the liver to get conjugated, to become water soluble, so that the bilirubin come out in the stool and in the urine. Okay, it has to be able to do that. The problem with it is the fact that the liver is immature, so immature liver will slow up the conjugation process. Okay, I have a new slide on this, but this one, you know, the one. But anyway, so just think about this. With the bilirubin, with the baby and the bilirubin, okay, the way to try to prevent the baby from getting elevated bilirubin levels is that the baby gets fed frequently, okay? So the baby should be fed every 2 hours, or every 3 hours. This helps to flush the bilirubin out into the stools and into the urine. So one of the ways to try to prevent the baby from having an accumulated amount of bilirubin is the baby needs to be breastfed or bottle fed frequently. Okay, that will help get rid of the bilirubin. The other thing is sometimes there can be a problem, of course, it's bilirubin. If the baby has jaundice, right, in the first 24 hours of life, then it's pathological. It's a pathological problem. This is a test question. It's a test question, you'll get that. The first 24 hours, okay, the first 24 hours, if the baby is born, and within that first 24 hours, the baby is jaundiced, it's pathological jaundice. After 24 hours, it's physiological jaundice, okay, meaning that the liver is immature. Pathological jaundice can occur if the baby is Rh positive and the mother is Rh negative, okay, and she never got her RhoGAM, okay. So that would be looked into if the baby has early signs of jaundice. Okay. If the baby does have jaundice, they will put the baby under what they call Billy lights. Have anybody seen the babies under Billy lights at all? What they do is that helps to break down the bilirubin. But the big thing about that is they don't want the baby to get dehydrated under the Billy lights. So they'll feed the baby, this is another test question, so they will feed the baby more often when it's under the Billy lights. Okay? And they will also put like a little eye mask on the baby. Okay? They will cover the baby with a diaper to protect his genitalia. And they will turn the baby every 2 to 3 hours, so all parts of the body will have exposure to the Billy lights. When the baby is under the Billy lights, one of the things sometimes you'll see is that the stools become a little looser on the baby. So again, you have to make sure that you clean the baby's bottom really well so it doesn't get a diaper rash. Okay, so you're worried about hydration, you're worried about keeping the eyes not exposed to the light. genitalia exposed to light. You want the baby to feed often and to turn the baby every 2 to 3 hours. Okay. So that will be the test question for you. Okay. The baby's gastrointestinal system adaptation. Okay, development of mucosa, barrier to prevent the penetration of harmful substances. The baby has the capacity, we should have these pictures. There's a picture of each day how much the baby has a capacity for as far as milk or bottles or breastfeeding. It's like 30 ml, I'll have to look it up again. It's like 30 ml the first day, but each day it expands because it has more and more food taken in, fluids taken in. The physiological capacity of the newborn stomach is considerably less than anatomically capacity. The cardiac sphincter is another test question. And I can tell you right now, you have to get it wrong. Every time I have this question, everybody gets it wrong. So, half of you better not get it wrong. You all have to get this right. It's a test question. Okay. The baby, do you notice babies spit up a lot? You see them spitting up a lot. That's very normal for the baby to spit up. Okay? And what happens is, they do have a small capacity. Their stomach has a small capacity. So you don't want to overfeed the baby, okay? And the other thing is burping the baby. If give you like 1 ounce or 2 ounces and then burp the baby. Okay, so that also helps with stopping the spitting up of the baby. Another reason why the baby spits up is because they have an immature cardiac sphincter. Okay? There's a nervous control of the stomach. It's immature, leading to regurgitation and uncoordinated peristalsis activity. So part of the other reason why the baby spits up, besides overfeeding and not burping, is this immature cardiac sphincter, okay, which doesn't close completely and causes the baby to regurgitate. Okay. Another test question. For the baby to gain weight, the newborn requires an intake of approximately, because you'll see different numbers in different books, approximately 108 kilocalories per kilogram per day from birth to 6 months of age. Some will say 108 to 110. Okay. So to gain weight, the baby needs to have an intake of 108 kilocalories to probably 110 kilocalories per kilogram per day from birth to 6 months. And have you learned anything like that in feeds as far as feeding goes yet? Feeding the baby? Okay, the stools. We all have that little thing that went around about colors of stools. The normal characteristics of stool. The baby should have its first meconium stool within 24 hours of birth. And within 24 hours of birth, the baby should have meconium. Meconium is considered sterile, okay? And it doesn't have a smell. It just comes out lots of it at the time. So meconium is a dark, tarry stool that comes out the first 24 to 48 hours or so. Then you have the transitional stool, which is more like a yellow, seedy kind of discharge. Okay, and then the milk stool. Okay. So breastfed newborns, they have a yellow gold, loose, stringy to pasty, foul-smelling stool. That's the milk stool. And the formula-fed babies, it's yellow, green, loose, pasty, or formed, and unpleasant odor. One of the people we had last week, one of the fathers last week, had said, it was interesting because he noticed that the baby had meconium stool, but by day 3, the baby started to have like a yellow stool. And he made some comment saying, oh, the milk came in because the baby's stool is now yellow. So this is thought kids. I'm just paying attention to kids. We're going to say. But I was like, wow. Right. Okay, when assessing the stool of a 1-week-old newborn who is being breastfed, which would the nurse expect to find?
Yellow gold. Yellow gold.
Yes. Yellow gold, loose stool. A 1-week-old newborn will be passing to milk stool, which in a breastfed newborn appears as yellow, gold, loose, stringy to pasty, and foul smelling. Greenish black tartar stool would suggest meconium. seedy greenish brown stool suggests transitional stool, and yellow-green stool, formed stool would be more likely with a newborn receiving formula. So know your stools.
Oh.
Okay, the renal system, usually the baby will be void within also the first 24 hours of birth. So, you know, people might say a little bit different, but they really want to see that the babies will have voided and had a stool within the first 24 hours of birth, which means everything's working, okay? They have a limited ability to concentrate urine until about 3 months of age. Urine will have a low specific gravity. They also will void, after the first couple of days, the first day or so of life, the baby doesn't have enough in it to void the 6 to 8 voidings in 24 hours, okay? Usually by day 3 and going home, the baby will void 6 to 8 voidings per 24 hours, and that's considered normal. So you have, a lot of times you have the breastfeeding mom who doesn't know if the baby's getting enough of her breast milk, okay? The way that she knows is that the baby will have 6 to 8 voidings within 24 hours. And sometimes they'll give the mom a chart to be able to, you know, put down how much the baby is voided in that 24-hour period of time. Usually breastfed babies will have more frequent stools, okay, just because of the makeup of the breast milk. So the baby might have more stools as opposed to a baby that is bottle fed who might have maybe 2 or 3 stools. The baby who is breastfed will have more. Okay. There is a low glomerular filtration rate and limited excretion and conservation capacity. It affects newborns' ability to excrete salt, water loads, and drugs. So it's immature, the baby's glomerular filtration rate. So you don't want to overfeed it too much, okay? Because it just doesn't have the ability to concentrate the urine. The immune system of the newborn, there's a natural immunity. The physical barriers or skin provides for immunity, okay, chemical barriers, resident non-pathological organs. Then they have an acquired immunity, okay. It's a development of circulating immunoglobulins, formation activated by lymphocytes, absent until the first invasion by a foreign organism or toxin. So they're able to develop this, activate their lymphocytes once it has some kind of infection going on. Then it will develop these, like I guess the lymphocytes will start to develop that only after they get the first. Newborn primarily dependent on 3 immunoglobulins, IgG, IgA, and IgM. The skin of the baby is also a protective barrier between the body and the environment. It limits the loss of water, it prevents absorption of harmful agents, protects thermoregulation and fat storage, and protects against physical trauma. The baby is really interesting to see because if the baby has a fractured clavicle, it's able to mend itself quite quickly because all their cells are young and they're able to reproduce themselves quickly for the baby. So also the same thing with their skin. The skin and their epidermal layer and all that. The baby sometimes will shed that first skin that the baby has, like a snake. So a lot of times the mom will be like, oh, the baby is cracking and the skin is cracking, and don't put lotion on the baby because the baby needs to get rid of that first layer of skin. You don't need to put lotion on the baby. Okay. Okay, neurological system development, they develop from their head to basically head to tail, and from inner to outer, okay, that's the development. So sometimes you'll see the baby flexed here and not flex on their legs because they are more developed. They start the development from up here and then they go down, okay. So they have an acute sense of hearing, smelling, and taste, okay. The baby is able to hear in utero. It recognizes its mother's voice. Okay. They say that the baby can hear outside noises besides the mom's gurgle and her heartbeat, you know, the baby's hearing sound from the parents. Some people will talk to the babies, you know, you can see, they've done studies where the baby will turn its head to the voice of the mother or father because it's used to hearing it in utero. So they have an acute sense of hearing. Okay. Smell, they're able to smell, and again, they can smell their mother for their, you know, the breast milk and all. They get familiar with the smell, and they're able to taste. They've shown pictures of babies where it has like sweet or sugar water, okay, and the baby really likes it because right off the bat we like sugar, right? Okay, so they're drinking they love that taste. But if you put a little salt in the water, they make a face, like a pungent face, like, oh, I don't like this. So they're able to taste right from the get-go. They're able to distinguish taste of what they like. So I guess we're just natural sweet lovers, I guess. Okay. Adaptation that happens with that, the respiratory, circulatory, and thermal regulation, the musculoskeletal system, and their central nervous system. Okay, reflexes is an indication of developmental, neurological development and function. So you see these different reflexes that the baby does, and it really is nature's way. When they have the sucking reflex or the rooting reflex, that's their survival. The rooting reflex, you ever go like this with the baby and they open their mouth and turn towards that, you know, whichever is being stroked, that's usually because of a nipple. And then once the nipple gets into the baby's mouth, they're able to suck. So that's all nature, you know, they're not thinking about it. There's a natural reflex. Okay, the nervous assessment of the sensory capacity of the newborn, which the following is the least mature sense at birth.
Vision.
Yes. Vision is incomplete at birth with the ability to focus on objects only in close proximity to the baby. The newborn has acute sense of hearing, smell, and taste. So a lot of times they say that the baby is not able to see real well, but it can see about 12 to 14 inches. So it's sort of like the way you hold the baby is able to look at you. Okay, that's at that point in time. All right, periods of reactivity, okay? This is a behavioral pattern that somebody had studied the baby and watching the baby have different periods of adaptation and behavior in the first few hours after the baby was born. So they watched this pattern in a lot of babies and they saw the similar pattern develop. So the first period of reactivity, this is from birth to about 30 minutes to about 2 hours after birth, okay? And during this time, the baby's heart rate might go above the 160 range. So this is when they first come out. Coming out of the womb, the sounds, the coldness, everything, they're reacting. So you might be able to see that the heart rate might be elevated because it's sort of, you know, everything's new, it's being stimulated, okay? Sometimes you see an increase in the respiratory rate, okay? The baby will cry. Okay, this is part of this first time coming out. The newborn is alert, moving, may appear hungry. So this is a time for the first, you know, from birth to about 2 hours after birth. The baby might be more reactive. As I said, the baby might, you know, the heart rate might be up a little bit higher and alert. Then we have a period of decreased responsiveness. And again, that is when the baby is anywhere from 30 minutes to 2 hours old. And this is when the baby is to sleep, will sleep a little bit, and have decreased activity. Sometimes, again, you'll see the baby do some of the startle reflex when it's sleeping. The baby just sort of startled, you know, when it's sleeping. So you have this period of less responsiveness for the baby. The vital signs get back to a normal level, and the heart rate and the respiratory rate will become a normal, you know, level for the baby. And then you have your second period of reactivity, and this is anywhere from 2 to 8 hours after the birth of the baby. The newborn is awake, shows an interest in stimuli. It might have its first meconium during this time, okay? It might show signs of hunger, like it wants to root and feed. during this second period of the activity. Okay? Is the following true or false? During the first period of the activity, a newborn is quite sleepy. Okay, during this period, the newborn is alert, moving, and they are hungry. Okay, good. Okay. Another responses the baby has is orientation. I'm not going to ask you this one. The only thing I would say to you is self-quieting ability, consolability. Okay, that sometimes you'll see the baby might be a little restless at 8. It's not like settling down yet. And what it will do sometimes is they'll take their fist or their thumb and put it in their mouth, and that soothes the baby, forces the baby to become calm. Okay, so that's that self-quieting ability that the baby can do. Suck on his fingers, suck on his fist. That allows the baby to relax on its own. Okay? And the other thing that I don't see here is the best time. I think it must be in the chapter there. The best time really for bonding with the mom is when the baby's in that quiet alert. Okay, quiet alert means the baby is looking around, not crying, not sleeping. He's just looking around. And this is like the best time, if you can time it, for bonding, because the baby's just very cute, looking at its environment, and looking at the parents, and just sort of staring and not crying and not sleeping. Okay. So I want you guys to take a break. Okay, so let's take a break.